Okay, today we discuss nodular patterns, especially the micronodular patterns. So on this CAT scan, the finding is, what's the finding? Yeah, so we have multiple calcified nodules. Now, the differential diagnosis for multiple calcified nodules, where the most common entity would be what to give you multiple calcified nodules?
TB.
Yeah, TB granulomatous disease, either TB, fungal infections like histoplasmosis can give you multiple calcified nodules. So that would be the most common thing. There are other unusual entities that can give you, other things that can be calcified are hamartomas, right? You can have multiple calcified hamartomas. What entity is associated with multiple hamartomas in the lung? Yeah, so carnes. What's carnes? Try it. Multiple pulmonary hamartomas. What else? Yeah, extraadrenal pheochromocytomas and so gastrointestinal tumors like in the stomach. So there would be GIST tumors in the stomach. Usually those are younger females. It's a very rare disease, okay? So, but for this particular case, this patient also has this study, which is what? It's a PET scan, and it shows
Metabolic nodule on the right.
Yeah, so what are we thinking about now? Well, first of all, could this still be granulomatous disease?
Yes.
Yeah, so, right, so you can have active granulomatous disease that gives you activity on PET scan. Anything else you might consider? Mets from what? Yeah, so calcifying metastases, so especially tumors like osteosarcoma and chondrosarcoma, which was the case here. So this was a patient with an osteosarcoma. So usually it's not a surprise that the osteosarcoma is established already when we find the nodules. The point is, in somebody with osteosarcoma who has calcified nodules, we can't assume that those nodules is granulomatous disease, right? So with osteosarcoma or chondrosarcomas, calcified nodules can be metastases. Here's a patient with multiple small calcified nodules. Now, there is an infection that can give you this appearance. What is that infection?
Miliary TB.
Miliary TB does not calcify, right? Miliary TB are small nodules. They're not calcified. Varicella gives you tiny calcified nodules. These are a little bit bigger than the varicella nodules. So this would be what infection? What fungal infection? Yeah, histoplasmosis, right. So histoplasmosis, the epidemic form, when they inhale a large inoculum, when that heals, they can be left with these scattered calcified nodules. Varicella gives you very tiny calcified nodules. It's an example of post-varicella, small calcified nodules. So this patient also has dense nodules here at the lung bases, but there's another abnormality, and the other abnormality is? Yeah, what's big in the heart? What?
Right atrium.
Right atrium. Anything else? Any other chamber?
Left atrium.
How do you know left atrium is big? There's a double density here, right? It's pretty subtle, right? Carinaal splenny, that's a tough one. Although, yeah, that is a sign of left atrial enlargement. So besides left atrial enlargement, what else is big? Yeah, so the main pulmonary artery here is big. So what does that combination of findings suggest? Pulmonary hypertension. With left atrial enlargement, if you have pulmonary hypertension, what's the underlying heart disease? Mitral stenosis and rheumatic heart disease, right? Now, how do you put that together with nodules like this at the lung bases? In patients with long-standing rheumatic heart disease, they can develop ossified nodules at the lung bases, right? Those are pulmonary ossifications, really a form of pulmonary hemosiderosis. What happens with the pulmonary hypertension that these patients have is that they can develop areas of bleeding that go on to ossify. So these are usually seen at the lung bases. These are found in cases of long-standing rheumatic heart disease with mitral stenosis, as in this particular case. So the differential of calcified nodules, TB, histo, calcifying metastases, varicella pneumonia, pulmonary ossification from mitral stenosis. Mets from osteosarcoma, it's usually established that they have the osteosarcoma, so it's not a surprise. Point is, if you have a calcified nodule in somebody with a history of osteosarc or chondrosarc, you can't assume that that is benign, that that is a granuloma. With varicella pneumonia, patients develop multifocal central lobular or peribronchiolar consolidations. When that goes on to heal, they can be left with small calcified nodules as a sequela of varicella pneumonia. So that is something else that might give you small calcified nodules. And then we talked about mitral stenosis. So they tip off big left atrium, big pulmonary artery. So if we see that in somebody with these dense nodules at the lung bases, then we can think of pulmonary ossification as associated with long-standing rheumatic heart disease, right? Patients are usually treated well before you would see this, but so this is more not something you would see in real life, although it may show up on an examination, right? So those are calcified nodules, or really ossified nodules from mitral stenosis. What's abnormal here? Normal or abnormal? Abnormal, grossly abnormal. So how would you describe this? You're on your phone with your attending. I'm looking at a chest x-ray and it shows, yeah, dense, yeah, these opacification throughout the lungs, right? So what could this be? You would suggest what?
ARDS.
All right, so ARDS can give you dense opacifications of the lungs bilaterally, certainly. What do you think of the mediastinum here? So lucid, right? So how would you explain that? Why is the mediastinum lucid?
Pleural disease, pleural calcifications.
Pleural calcification?
So the lungs are calcified?
Well, what about the pleura here? Well, thickened, or what's the attenuation? It's less dense than the lungs. What about the abdomen? It's also less dense than the lungs, right? So is this consolidation in the lungs, or is this something else? Consolidation gives you the same attenuation as the soft tissues, right? It doesn't make the lungs denser than everything else. So if the lungs are denser than everything else, now you're thinking about what? Calcification, right? So what entity can give you diffuse calcification like that within the lungs? Alveolar microlithiasis, right? Pulmonary alveolar microlithiasis, and it also has a pathognomonic finding on this study. What is this study? Yeah, if you read in radiology, you can always figure out what they're showing you, right? So that's a bone scan, and it shows increased activity within the lung. So the increased metabolic activity and the increased calcium metabolism in the lungs can give you increased activity on the bone scan, which tends to be this pathognomonic finding of pulmonary alveolar microlithiasis on a bone scan. So this, of course, is very rare. It can be familial. The etiology is unknown, but inborn error of metabolism is what we blame it on. Patients, so it has a range, a spectrum. Patients can be asymptomatic, but when it gets very far advanced, as in that case, then you might have respiratory symptoms. So usually it's not quite so dramatic, and it's a tough one to really diagnose by the chest X-ray. I mean, you look at this, and small calcified nodules is not the thing that comes to mind. But it's described as a sandstorm appearance. So it's described as if somebody sprinkled sand all over the chest radiograph. All right, so these dense small nodules. So that can be very sneaky to realize that when you're looking at a chest radiograph there. Okay, the fact that, or what's called the black pleural line, because the lungs are denser than the pleura, so the pleura shows up here as lower in attenuation than the lungs because the lungs are calcified. So that's a finding that can be associated with alveolar microlithiasis. It's not hard on CT. On CT, we can see the calcifications within the lungs. You see these scattered small, tiny calcifications throughout the lungs, and we can say, all right, so this might be a case of alveolar microlithiasis. Okay, and then we talked about bone scan. That's going to have increased activity there on the bone scan with alveolar microlithiasis and the black pleural line. Although it's been said that that might also represent a little bit of cystic change in that region, small subpleural cysts, but that finding is also associated with alveolar
If we find that, get that case, right, like in a non-con CT of the chest, would you recommend contrast after to look at the mediastinum or not?
No, you don't need contrast. Why would you want to look at the mediastinum if you see?
Notes, like kind of lymph nodes.
Well, you can see usually CT is good enough to look for lymph nodes even on a non-contrast CT, right? So, and it's not going to matter that much if the nodes are small. This radiograph shows, well, I kind of told you, right? You see the opacities. Where are the opacities? Can you do better than that? Come on, I mean, we're in the lungs.
Right, lung base mass.
Right middle lobe and, yeah, well, left lower lobe,
Right.
right lower lobe. You see anything back here? No, I see them over here, right? So where are they gonna be? Right middle lobe and lingular, right? Now, what's unusual about the CT when you look at these opacities?
They're very dense.
How dense? They're calcified, right? It's calcification. Now, something else unusual about this one, what you notice that it has an air bronchogram, right? So you have these calcified consolidations, or how can you have calcified airspace disease with air bronchograms, right? So what could this be? Well, there's a clue. There's a last image there. What's the finding on the last image?
Atrophic kidneys.
Yeah, the kidneys are atrophic, right? So this patient has what? Yeah, end-stage renal disease. So how do you put that together with the finding in the lungs? What is this? So, yeah, so these are metastatic calcifications from a metabolic derangement that's associated with end-stage renal disease, right? This is called metastatic calcification. It can be associated with renal failure. So these patients can develop calcifications anywhere in the body, but especially in regions of the body that are acidotic because of their calcium and phosphate metabolism. So you can see calcifications in the stomach and in the lungs, okay? So, of course, the renal failure is associated with acidosis, hyperparathyroidism, hyperphosphatemia, vitamin D problems, elevated calcium, phosphate. So that contributes to this calcification that can occur within the soft tissues, all right? Okay, chest radiograph, normal or abnormal? That's the easy question. Of course, he's abnormal. So how would you describe the abnormality? What would you say? Big nodules or small nodules? Micronodules, right? So there are many small nodules here scattered throughout the chest. What do we call this pattern? A diffuse micronodular pattern. The other term for that is miliary, right? So this is a miliary pattern. We have a diffuse micronodular pattern here within the chest. All these small nodules scattered throughout the chest, okay? Well, here's a CT on this particular case, and you all should be familiar now with how do we approach the micronodular pattern on CT. How do we approach that? Well, there are the distributions, right? So the three distributions that we have to know are random, perilymphatic, and central lobular, right? So now how do we tell them apart? First you ask yourself a question, and the question you ask is? Yes, so you say self, are the nodules touching the pleural surfaces? And the answer here is yes. If the nodules were not touching the pleural surfaces, then you would have central lobular. The fact that the nodules are touching the pleural surfaces means you must decide between random and perilymphatic. So the next thing you do is what? So here, what do we think then? And why do you say that? Because to differentiate between random and perilymphatic, what do? We look at, you look at the fissures, right? You look at the fissures, you look along the interlobular septae to decide, is there a preponderance of nodules along the fissures or along interlobular septae to say that it is a perilymphatic distribution of nodules. So here, what do we think? Random. Here we think random. Now, there's a difference in pathophysiology between all three of those distributions, all right? So the pathophysiology that gives you a random distribution of nodules is what? Hematogenous dissemination. The pathophysiology that gives you a perilymphatic distribution of nodules, or more, the two big things in that differential diagnosis would be sarcoid and lymphangitic carcinomatosis, right? So those are the two big things in the perilymphatic distribution category. And then we have central lobular nodules. Usually the pathophysiology of central lobular nodules is endobronchial, right? So something that's affecting the central lobular airways. So something affecting the airways, endobronchial spread. Okay, so this patient also has this interesting finding. Of course, when you have a random distribution of nodules, the first thing that comes to mind is, that's not the first thing. Yeah, TB, miliary TB or miliary fungal infection. But this patient has this finding, which is metastatic disease in the liver, right? So METs can also give you a micronodular pattern. The tumor that you're supposed to think about when we have a micronodular pattern for metastatic disease, what is the tumor we're supposed to think about? Thyroid, right. So papillary thyroid cancer is the tumor that you're supposed to think about first. But any tumor can do it, and the neoplasm most likely to metastasize to the liver is colon cancer. This was a patient with colon cancer who presented with a micronodular pattern. Right? So even though when we have that miliary pattern, the first thing we think about is infection, like miliary TB, miliary fungal infection, realize that any tumor can also give you a micronodular pattern, although you have to be aware of thyroid because that's the one that's notorious for doing that. Another patient with a micronodular pattern, you ask yourself the question, what question do we ask? Are they touching the pleural surfaces? The answer is yes, so we must decide between, no, we must decide between random and perilymphatic, and then you ask yourself, are they studying the fissures? And are they along? And the answer here is yes, so we are left with perilymphatic, right. And the two things in that, the two big things are sarcoid and lymphangitic carcinomatosis. Here we favor, why? Yeah, so the hylo look big, so it looks like you might have bilateral hyalurolymphadenopathy. What's another reason you favor sarcoid over lymphangitic carcinomatosis? Lymphangitic carcinomatosis is associated with more interlobular septal thickening, whereas sarcoid tends to be more nodular. So the more nodular the disease is, the more you would favor sarcoid. The more interlobular septal thickening you have, especially nodular interlobular septal thickening, then there you would favor lymphangitic carcinomatosis. I haven't shown you the upper and lower regions of the lungs, but there's also a difference in the distribution. What's different about the distribution of sarcoid versus lymphangitic carcinomatosis? Sarcoid favors upper, right, mid to upper lung distribution, whereas lymphangitic carcinomatosis is usually more of a lower lung distribution. Right? But this was a case of sarcoid. Okay. So there's another patient with nodules. Now we talked about the distribution when you're looking at a CT for a micronodular pattern. When you're talking about a chest radiograph, how do you approach the distribution? What are the two different distributions on a chest radiograph that you consider? Upper versus lower, right? So if you have a lower lung distribution of nodules or a miliary pattern or micronodular pattern on chest radiograph, there you think what? Mets or because of the mode of spread is hematogenous, right? So hematogenous spread favors the lower lungs. So there you would favor hematogenous dissemination. What's the distribution here? Upper. Now what is the differential diagnosis for nodules in an upper lung distribution on a chest radiograph? Like? Yeah, so silicosis, co-workers pneumoconiosis. What else can give you an upper lung distribution of nodules on a chest radiograph? Sarcoid, yeah, certainly. Sarcoid's in the differential. Anything else? Well, borreliosis is this, you can store that on the same neuron as sarcoid. Sarcoid. That's very similar to sarcoid. Anything else? Well, hypersensitivity pneumonitis, the nodules, what's different about that versus this? That can also give you disease in an upper lung distribution, but they tend not to be as dense, right? So they're a little bit, they're not as dense as these nodules with HP. So this patient does have nodules here throughout the lungs and has this finding, which is eggshell calcifications. And eggshell calcifications is most closely associated with silicosis, right? So this was a case of silicosis. Here's another patient who has nodules here more of an upper lung distribution of nodules, okay? So there they are. But the CT looks like this, and this is the disease you did not mention for upper lung distribution of nodules. Langerhans cell histiocytosis, right? So now, how do you make that diagnosis on the CT? We look for what? Yeah, so cysts and nodules, right? So you have nodules and cystic disease. It's not the best example, but there is a particular sign that's associated with LCH. When you have a nodule like that that kind of looks cavitary with a slightly thickened wall. Does anybody know what that sign is called? What'd you say? No, the halo sign is ground glass around the lesion, okay? That's not this. Nobody? It's called the Cheerio sign, because it looks like a Cheerio, right? Of course. I guess you're all Captain Crunch fans. Okay, so the micronodular pattern, micronodular, miliary, reticular nodule, they all have a similar differential diagnosis. We can also correlate that clinically. If the patient is sick, we think of infections, miliary TB, miliary fungal infections, some other unusual things that can also give you a micronodular pattern. But miliary TB, miliary fungal infections will look the same. They give you a random distribution of small nodules throughout the lungs. Tends to be lower lung predominant because it's hematogenous dissemination. If the patient is not sick, MET, sarcoid, LCH, pneumoconiosis, hypersensitivity pneumonitis, we saw alveolar megalolithiasis, and we've seen that that's a little bit different. That has somewhat of a different appearance than these other entities on CT and on the chest radiograph. So there's this very nice flow chart that took me, you wouldn't believe how long it took me to make this up. You don't know how hard it is to make up these flow charts in PowerPoint. But anyway, so if you have nodules, you ask yourself, are they touching the pleural surfaces? Yes or no? No. Central lobular, there we think infection. Is there tree and bud? Yes. Then we think TB, atypical mycobacterial infection. No, could still be TB, but there are some other diseases there also that might give you that central lobular distribution. And we already discussed random versus perilymphatic, miliary disease versus metastatic disease for random hematogenous dissemination, and then sarcoid lymphangitic tumor, although silicosis, co-workers pneumoconiosis, that can also look like sarcoid, might also give you a perilymphatic distribution at times. Okay. So micronodular metastases, thyroid is the tumor. There are other tumors that can also do it, especially upper abdominal tumors like pancreas, but any tumor can give you micronodular disease from metastatic presentation. And we saw this case already of colon cancer with mets to the lungs and to the liver. Okay. So sarcoid can give you a reticular nodular pattern, mid to upper lung distribution of abnormalities. The clue is always you have bilateral symmetric hilar lymphadenopathy. Whenever you have bilateral symmetric hilar lymphadenopathy, always consider sarcoid in your differential diagnosis. Okay? And then so we can have nodules with sarcoid, but what might be characteristic with sarcoid is that the nodules can have a perilymphatic distribution. So they can be along bronchi, along vessels, along the fissures, especially along the interlobular septae. So if you have nodules that are along the interlobular septae, like that, especially this studying of the interlobular septae, along the fissures, studying the fissures, and then along interlobular septae. Here's a nice example here of here's another nice one, right along the interlobular septae. So nice examples here of a perilymphatic distribution from sarcoid. LCH, this can also give you an upper lung distribution of disease. It can have a nodular phase, so it can be predominantly nodular, especially at the very beginning. When it progresses to formation of cysts, and then those cysts can coalesce, and then you can be left with bullae, blebs, and severe emphysema in the later stages. So you can have a reticular nodular pattern, upper lung distribution. It's also associated with air traffic. So these patients can have increased lung volumes on the chest radiograph with LCH. The activity that these patients, this is associated with, LCH is associated with, what activity? Cigarette smoking. Over 90% of these cases will be smokers. Okay? So it can be predominantly nodular, where you have a predominantly reticular nodular pattern there on the chest radiograph, But as it progresses, it can start out as nodular, then you get this cavitation within the nodules, and the nodules then transition and form these cysts, and then the cysts can't coalesce to form bullous disease in the later stages of LCH. So cysts and nodules, though, that's what we look for on CT when we're thinking about LCH. The Cheerio sign, right, is associated with LCH. Silicosis can also give you upper lung distribution of nodules. So this is caused by inhalation of dust containing silica, mining, quarrying, tunneling, sandblasting, artificial quartz, people who work on countertops, making countertops. So all of those things are predisposing factors for silicosis. What happens is that the macrophages try to ingest the particles and they die, releasing their enzymes, and that's what results in the fibrosis from silicosis. They can also carry it to the lymph nodes in the hyla, so that's why you can have lymph node changes also in patients with silicosis, the calcification of the lymph nodes. So the silicotic nodule, the hyalinized nodule in the lung, that's what the pathologist looks for. When these nodules coalesce, then we can have larger fibrotic masses, and that is called progressive massive fibrosis. So it starts out as nodules, and then these nodules can coalesce within the lungs to give you larger fibrotic masses, and that is progressive massive fibrosis. There is increased susceptibility to tuberculosis in these patients with silicosis. Okay? This is a 29-year-old with shortness of breath. This person worked in a diamond mine, had this very unusual looking chest radiograph here, and the CT looks like this. So what's going on here on the CT? So what is this sign called? That is the angel wing sign, right? So notice that you have these opacities in the lung parenchyma, but they have these lateral borders here are kind of parallel to the pleural surfaces. So that's called the angel wing sign of progressive massive fibrosis. So these opacities, they coalesce, they retract towards the hyla, leaving behind emphysematous lung. Right? So this is a patient who's developed progressive massive fibrosis from exposure to silica, from silicosis. Usually it takes years for this to occur, right? But this occurred pretty rapidly in this person, so we call this what? Accelerated silicosis, right? So it's called accelerated silicosis. So the different patterns that you can get from silicosis, there's acute silicoprognosis. So this is from an acute massive exposure. These patients develop consolidations that actually has protein in it, very similar to pulmonary alveolar prognosis. There's simple silicosis that gives you nodules. There's accelerated silicosis where the changes accelerate rapidly. There's complicated silicosis, and that's where the nodules coalesce and you develop progressive massive fibrosis. And then there's Kaplan syndrome. Who remembers what Kaplan syndrome is?
Rheumatoid arthritis.
Yeah, so those are patients with rheumatoid arthritis who are also exposed to silica, and what do they develop in the lungs? Yeah, they develop an accelerated formation of rheumatoid nodules within the lungs, and that's Kaplan syndrome. So acute silicoprognosis, this is from a short duration, massive exposure. They get lung damage, and so this occurs weeks to months after the exposure. And they develop an alveolar prognosis, looks like pulmonary alveolar prognosis, even on pathology. And so they will have these kind of ground glass consolidations throughout their lungs. So that's from a massive exposure to silica. So usually sandblasters might get that, okay? So that's acute silicoprognosis, occurs very shortly after exposure. So they develop predominantly ground glass opacities, can also form nodules. They can also have nodules within the lungs. Simple silicosis, these patients develop nodules, no symptoms or changes in pulmonary function, has a long latency period. Complicated silicosis, the nodules coalesce to form opacities greater than 1 centimeter. That is associated with symptoms and disability when you get coalescence of the nodules. So accelerated silicosis, exposure to high concentrations of silica over a short period of time. The changes of simple silicosis occur in just a few years. So just a few years after exposure, they develop nodules, upper lung distribution. This one is a little bit starting to form eggshell calcifications there within the right hilar node. And then we already talked about Kaplan syndrome rheumatoid nodules in patients with rheumatoid arthritis who also have exposure to silica. So for simple silicosis, multiple nodules may calcify, they might have a particular nodular pattern. Eggshell calcification of nodes, that is most strongly associated with silicosis. So upper lung distribution of nodules, that's what we look for silicosis, and we saw a case of the eggshell calcifications already, right? So that is most strongly associated with silicosis when we see that. And then when we get progressive massive fibrosis, these opacities coalesce, tends to have an upper lung distribution. It pulls on the adjacent lung, so you have architectural distortion of the surrounding lung. You also get peripheral emphysema, and that emphysema contributes to the dysfunction, to their respiratory symptoms. The diseases that can give you progressive massive fibrosis, these are diseases that have an upper lung predominance of fibrosis. So what are diseases that can give you progressive massive fibrosis? Well, we're talking about, right, silicosis, co-workers pneumoconiosis, right? What are other diseases that can give you progressive massive fibrosis? Upper lung fibrosis, what disease? Yeah, sure, sarcoid, absolutely. So sarcoid can also do it in what infection? Well, more likely than that would be TB, tuberculosis, right? So those are diseases that are associated with progressive massive. Well, that gives you upper lung fibrosis, but it tends not to give you mass-like fibrosis like this, okay? So eggshell calcifications, progressive massive fibrosis, right? So this was an example of silicosis. So that's what we see with complicated silicosis, progressive massive fibrosis. This tends to affect the upper lungs. These masses, they contract towards the hila. The midgate cavitation, the angel wing sign, is when the lateral borders here are kind of parallel to the pleural surfaces. So that's what we get with complicated silicosis. And this is as good as it gets: progressive massive fibrosis, eggshell calcifications, emphysema in the adjacent lung. So this is silicosis with progressive massive fibrosis. Here's what it looks like on CT. Nodules coalesce to form these larger fibrotic opacities. They pull on the adjacent lung, architectural distortion, peripheral emphysema. So this is what we see with progressive massive fibrosis. So you can have superinfection with TB. We can have deterioration of lung function that tends to be associated with the emphysema that is also found in these patients. Okay? Cavitation can occur sometimes from superinfection with TB, or sometimes it just occurs on its own spontaneously. Now, co-workers pneumoconiosis occurs from coal inhalation, and although the pathologic lesion is different, as far as we're concerned, it looks exactly the same. So as far as the changes from co-workers pneumoconiosis versus silicosis, they look exactly the same radiologically, so there's nothing different to learn. The cold macule is the pathologic lesion, so although that's different than the lesion we see with silicosis, we're not going to see that. We see the radiological manifestations. And radiologically, co-workers pneumoconiosis is indistinguishable from silicosis. So you can have simple co-workers pneumoconiosis where we have nodules in an upper lung distribution, or we can have complicated co-workers pneumoconiosis where we get progressive massive fibrosis. So simple co-workers pneumoconiosis, nodules. Complicated co-workers pneumoconiosis, the nodules coalesce to form these larger fibrotic opacities, and that's progressive massive fibrosis. Now there's a particular sign that we can see as these nodules coalesce to form these larger fibrotic masses. You know what that sign is called? It's usually associated with sarcoid, with progressive, the galaxy sign, right? So this can look like sarcoid, right? So sarcoid can, that's why sarcoid can also give you progressive massive fibrosis. So upper lung progressive massive fibrosis in the lungs can be sarcoid, silicosis, co-workers pneumoconiosis. Now there are other dusts that can cause pneumoconiosis. These are the inert dusts, iron, tin, barium. These are not associated with fibrosis, so here the X-ray looks much worse than the patient because these are very dense. We will see these on the X-ray as very dense particles, but usually patients are not symptomatic. So stenosis here from tin, very dense particles. So these are inorganic dust. These do not cause fibrosis, okay? But the X-rays look very bad because they are so dense. All right, so here's a patient who has some nodular opacities here, upper lung distribution. Anything else look abnormal?
I don't know.
Yeah, you might wonder about the highlight there, right? Upper lobe nodules works in a factory that makes light bulbs. Who said it? This is berylliosis, right? So berylliosis looks just like sarcoid. And, the only way you're going to make the diagnosis is to get the occupational history of the exposure to beryllium. But the changes will look just like sarcoid. Upper lung nodular distribution, they can also develop lymphadenopathy. And so fluorescent bulbs, aircraft brake linings, high levels of beryllium, they might get a toxic pneumonitis, but the chronic berylliosis looks like sarcoid, okay? And they also get non-casein granulomas, so they get a similar lesion on pathology. So the granulomas can form in the lung, skin, lymph nodes, liver, spleen. Salivary glands, eyes, bones, CNS spared, unlike sarcoid. That's the difference. But as far as the lung manifestations, it can look just like sarcoid. So they can develop nodules, they can have perilymphatic distribution of nodules, they can have lymphadenopathy. So they can develop lymphadenopathy, perilymphatic nodules, just like we can see with sarcoidosis. So it's the history, the only way to make the diagnosis with chronic berylliosis. More examples, looks just like sarcoid, perilymphatic nodules, upper lung distribution of disease with berylliosis. Here's an end-stage case of chronic berylliosis. There was actually an outbreak of this in Newark, where they had a light bulb factory here, and patients were coming in with berylliosis. It was well before my time, but anyway, chronic berylliosis. This was a case from here. This was a case from Newark. Somebody else with upper lobe opacities here, right? Architectural distortion, progressive massive fibrosis. This was sarcoid, okay? So sarcoid can also give you progressive massive fibrosis. Looks like an angel wing sign there also. Bilateral hydrolymphadenopathy, perilymphatic nodules. So sarcoid, Kohlberger's pneumoconiosis, all of those things can give you progressive massive fibrosis. What is going on here? Here we have nodules coalescing into a larger opacity. What sign did we say this was? Galaxy sign. So these things we will call what? Are they tumors? No. So what are these? These are, we just saw 20 examples of these. What do we call this? Progressive massive fibrosis, right? What's unusual about this case, though? Yeah, they're very high in attenuation. So what pneumoconiosis can give you progressive massive fibrosis that is high in attenuation? This is talcosis. All right, so the talc particles are high in attenuation from inhalation of talc. When it coalesces, it can give you very high attenuation progressive massive fibrosis. So that's talcosis. Normal or abnormal chest radiograph? What is abnormal? Well, first of all, what do we think of the lung volumes here? Yeah, the lung volumes are increased. What else is abnormal?
Probably interstitial.
Yeah, where?
Diffusely.
Diffusely, is the upper look worse than lower?
Right lower lung as well.
So here I would say it looks like maybe a little bit worse in the upper lungs, okay? And the CT looks like this. So what's abnormal on the CT? What do you have? Ground glass opacities, right. So we have ground glass opacities here. The distribution of these opacities is what? Central. Yeah, central, which is really the only distribution you can have with ground glass opacities. So what are we thinking about here? Hypersensitivity pneumonitis. This is a patient with hypersensitivity pneumonitis. So air trapping, increased lung volumes, central lobular nodules, especially ground glass attenuation. And then on the coronal images, what kind of reconstruction is this? Well, what is it showing you? Oh, you have some apical pleural thickening, but what else do you see here? What do you think of the airways? What kind of bronchiectasis?
Traction.
That's traction bronchiectasis. So it's demonstrating the fibrosis here. There's traction bronchiectasis. So what kind of reconstruction is this that shows you the airways so nicely? Is this a MIP? No, this is a MINIP, right? So if you want to look at airways, so MIPS you use if you want to look at dense structures. If you want to look at vessels, you use MIPS, maximum intensity projection. If you want to look at airways, if you want to look at emphysema, if you want to look at low attenuation structures like air, there we use MINIP reconstructions, okay? So those are good for looking at the airways. The classic appearance, central lobular ground glass attenuation nodules, right? That's the classic appearance of hypersensitivity pneumonitis. Now, there are other things that can also give you central lobular ground glass nodules. What are some of those other things? Yeah, so respiratory bronchiolitis, right, which is associated with smoking, right? That can also give you inflammation around the central lobular bronchiole. That can give you central lobular ground glass opacities. And you can also have infection, bronchogenic dissemination of infection. Sometimes with TB or aspiration can also give you central lobular nodules of ground glass opacity, right? But we're thinking of airway diseases. That's the point. When you have a central lobular distribution of ground glass opacity. We can also have air trapping. So on expiratory views, we look for air trapping with hypersensitivity pneumonitis. So hypersensitivity pneumonitis, this is a reaction to organic antigen. So inhalation of organic antigen results then in inflammation around the central lobular airways, which is why we have the central lobular ground glass opacities on CT. So on PATH, they will find cellular bronchiolitis here centered around the airways with hypersensitivity pneumonitis. The disease is named by the antigen: farmer's lung moldy hay, bagasosis, sugarcane, humidifier lung, thermotolerant bacteria, pigeon breeders from exposure to birds, and hot tub lung from atypical mycobacteria that can grow within the hot tubs and gives you like a hypersensitivity pneumonitis kind of reaction within the lungs. Okay. Now, it was described, that used to be described in 3 stages. Now we divide it into fibrotic or non-fibrotic versus fibrotic forms of disease. It is possible with a prolonged exposure, an initial prolonged exposure, to actually develop consolidations, mostly ground glass consolidations. And then what used to be the subacute form is when you would have central lobular nodules with hypersensitive pneumonitis. It causes fibrosis with chronic hypersensitive pneumonitis, and it might be upper lung predominant. On CT, we look for ground glass, central lobular nodules, air trapping, fibrosis, and emphysema. So acutely, you might have areas of air trapping, mosaic attenuation with ground glass opacities with hypersensitivity pneumonitis. And if you're looking for air trapping, you want to do expiratory views because that shows you the air trapping much better than your usual inspiratory views. So expiratory views will show you the air trapping nicely with hypersensitivity pneumonitis. And it's that subacute stage where you get the central lobular nodules that is the most characteristic appearance of hypersensitivity pneumonitis. So with chronic hypersensitivity pneumonitis, you'll get fibrosis, you have reticular opacities, but what's also characteristic is air trapping, areas of emphysema. So if we have fibrosis mixed with areas of emphysema, then that's a clue that, we may be dealing with not UIP, not IPF, but hypersensitivity pneumonitis. All right? So IPF gives you the classic peripheral subpleural honeycombing. With chronic hypersensitivity pneumonitis, you get fibrosis, but you also have areas of emphysema. that are mixed in. So if there's pronounced air trapping and emphysema mixed in with your fibrosis, you should consider chronic hypersensitivity pneumonitis. The non-fibrotic manifestations, this is where we have central lobular nodules, especially ground glass. At this point, it's reversible if the patient is treated. Poorly defined central lobular nodules. Ground glass opacity, mosaic attenuation mixed with air trapping. There is a sign that's associated with hypersensitivity pneumonitis where you have these secondary pulmonary lobules of ground glass opacity, secondary pulmonary lobules with air trapping kind of mixed in. What is that sign called?
Head cheese.
That's the head cheese sign, right? So that sign can also be associated with hypersensitivity pneumonitis, right? And so on expiratory views, you will see the air trapping better than on the inspiratory views, of course. And then with the fibrotic stages, there we will have pronounced air trapping mixed in with architectural distortion in regions of fibrosis. When we have chronic hypersensitive pneumonitis, there's a relative sparing of the lung bases with hypersensitivity pneumonitis. And it can be upper lung predominant, okay? The fibrosis can be upper lung predominant with hypersensitivity pneumonitis. And then even the reticular changes sometimes, if they're treated, may improve after proper treatment, okay? So that is our discussion of nodular patterns. So next time we will have a quiz. Any questions? Nope. Okay. See you guys next time.